edit a nice last guideline slide, and then we will see how things. So, okay, I'm ready. Now let me find you the link, okay? Vijay, I send you the link and the PDF paper, and then you can.
I'll do that. I'll send it to others.
Yeah.
Okay.
Am I audible?
We will be live in 30 seconds.
You're audible.
Aarti, am I audible?
Yes, sir, perfectly.
Here's the link. Cheers, Stefan, okay? And the PDF is included as well. Indrajit, I also send you the link and the guidelines. So, and Vijay.
We need 1 more minute.
Yeah,
Just a
thank you,
second.
sir. Thank you.
And you share it with everybody.
Sure, sir. Sure.
It's 5 megabyte. I hope it does go through, but otherwise just tell me and then.
So it's 3, 2, 1. We are live now, sir. Over to you.
Very good evening to all the doctors and greetings from Lupin Limited. Myself, Rohit Nayyar, and on behalf of Lupin, I welcome everyone to attend this International Heart Symposia focus on Emperor Preserve trial. It's been a remarkable day for heart failure patients. As we all know, heart failure is emerging as a major health problem in India, with a reported mortality of nearly 60% at 5 years, which is higher than many common cancers. Specifically, heart failure with preserved ejection fraction is a global public health crisis responsible for a high burden of mortality and morbidity and becoming the dominant form of heart failure in aging populations. Till now, there has been no proven therapy for HFpEF patients. We have now officially proven therapy for HFpEF patients in India, empagliflozin, with proven benefits in both primary and secondary endpoints. To discuss in detail, I welcome our today's speaker, Dr. Stephen Anker, who is a professor of cardiology, Department of Cardiology, and he's also the principal investigator and speaker for today's session. So welcome to Dr. Stephen Anker. I also welcome our moderator for today's session. He is the chief investigator and moderator, Dr. V.K. Chopra. He is the senior director, clinical cardiology, heart failure and research, Max Super Specialty Hospital, New Delhi. Welcome, sir. Also, we have the 3 Indian panelists and the Indian armed investigators and the 3 top key opinion leaders of India. I welcome Dr. Ajit Mulasari, Director of Cardiology, Institute of Cardiovascular Disease, Madras Medical Mission, Chennai. Welcome, Dr. Ajit. Also, we have the pleasure of having with us Dr. Dhiman Kahali. He is the Director, Intervention Cardiology, BM Birla Heart Research Center, Kolkata. Welcome, sir. And we have also with us Dr. Shrikant KV. He is the Consultant Intervention Cardiologist, Narayana Institute of Cardiac Sciences, Bangalore. Welcome, sir. And with this now, I will hand over the session to Dr. VK Chopra to just set the context and starts the today's session. Over to you, sir.
Thank you, Rohit. As you very rightly mentioned, probably more research has been done in the field of heart failure than any other field in cardiology in the last few years. And this has given us wonderful therapies, dominantly focused on managing our patients with heart failure with reduced ejection fraction. The 5-year mortality in Western world is about 50%, but let me tell you, Rohit, the data from our countries shows close to 50-60% mortality even at 3 years of time. So it's a much bigger problem for us, and so we definitely need therapies. While the incidence of heart failure with preserved ejection fraction in the Western world is reported as close to 50% or more, in our country, most of the registries still mention 20 to 30%. Now, it could partly be that actually it is a little bit less, but also because many of these cases go unrecognized, because unfortunately in our country and in several other places, a normal ejection fraction on echocardiography translates as no heart failure in people's minds. So first of all, we need to set that right, that you can have significant heart failure even with a relatively preserved ejection fraction. Preserved ejection fraction is a disease with varied etiologies and many phenotypes, and therefore several trials have been done. 1 or 2 of them came close to success, but they did not quite cross the line. So that's why yesterday was a landmark day in the field of heart failure management, because for the first time, Dr. Anker presented the results of Emperor Preserved study, which unequivocally demonstrated a very significant benefit in this group of patients, as we will hear from him shortly. There are several issues involved here. There are renal factors, there is diabetes, there is heart failure, and now we know that it is not just one disease alone, it's a complex interplay of several factors. So with these, we keenly look forward to listening to Dr. Anker, who's a fantastic speaker. He conducted this trial in these difficult COVID times, successfully brought it to its conclusion, which is a tribute to his hard work and dedication and driving force. Stefan, over to you. Welcome.
Well, thank you so much for allowing me to present here. And it's really my utmost pleasure to give the first presentation after the hotline at the ESC in this session here today with you. Let me share my screen and I hope you can basically see already my slides, and I hope you can now see them.
Yes, sir. Yes.
Full. So basically, what I plan to do here is to present to you the little journey from type 2 diabetes to heart failure to Emperor preserved and pooled data as they were shown for the first time yesterday and just published, and discuss this in the context of the new guidelines that also came out yesterday. Now, when you basically look at the whole problem, I will start by simply putting the overall picture here that patients with a diagnosis of diabetes, they are told that you're losing lifetime. 6 years with the diagnosis of diabetes, and when you then also diagnose an infarct in these patients, so because they had cardiovascular risk factors and finally significant cardiovascular disease, then you actually have a patient in front of you with a 12-year reduced life expectancy. And I would say we need to give something back to them. But then comes the next step. They develop heart failure. And so heart failure causes reduced exercise capacity and poor quality of life. It dramatically increases the risk for repeat hospitalization and mortality. And heart failure, of course, is a burden to society, but also to the patient. And in many situations, patients have to cover at least part of the cost themselves. And so it's really, for all parties involved, an expensive disease. Millions of patients have this problem. Now, in heart failure with reduced ejection fraction, we are getting much better in trying to solve this problem. But in heart failure with preserved ejection fraction, there is still a lot to do. And half of all heart failure patients in the world are such HFpEF patients. We have tried to resolve this problem somehow in the last 15 years. 5 big trials failed. Well, and now we try to do better. Targeting diabetes can be done with different drugs. Here, the focus is on Sglt2 inhibitors, but just let's remind ourselves that there's also GLP-1 agonists and DPP-4 inhibitors. So management of diabetes can be done in different ways, but for cardiovascular problems in diabetes, moving then on to heart failure, the lead is with Sglt2 inhibitors. Sglt2 inhibitors, they basically are drugs that block the reabsorption of sugar. When you do that, the urine becomes full of sugar, therefore of calories. And with the glucosuria, you not only then have some degree of weight loss, but also small reductions of blood pressure. And of course, a management of glucose where hemoglobin A1C goes somewhat down. And all of this together gives you benefits. Now, many trials have happened in the field. And sometimes out of bad things, good things come. When I say that, I mean that the early trials of some anti-diabetic therapies have actually shown that some of them increase rather than decrease cardiovascular outcomes. So it was considered necessary about 10 years ago to institute a full rule that new anti-diabetic medicines should have cardiovascular safety outcome trials where at least a non-inferiority compared to the control group needs to be documented. But then, of course, once you have non-inferiority documented, you may actually show superiority. And the first drug that did that successfully was empagliflozin with the EMPA-REG outcome trial, published 6 years now ago, putting this drug in the line of the breakthrough inventions with statins and with ACE inhibitors to prevent cardiovascular disease and cardiovascular bad outcomes. Now, with the number of trials done in diabetes came the recognition that there is some class effect for the reduction of heart failure hospitalizations and renal composite outcomes. And with this basically came then the idea that maybe heart failure itself could be a target. Heart failure and diabetes, they are a bad liaison. There is quite many patients in heart failure who have diabetes, and very many patients with diabetes develop heart failure. So really doing something about these patients is warranted, particularly because in the diabetes trials, heart failure was not a classical inclusion criteria. It was observed in some cases, but not mandatory to be present at baseline in any patient. There was minimal effort to characterize the heart failure subgroup in diabetes patients. Here, the data from the EMPA-REG outcome trial heart failure subgroup, about 700 patients. And you can see here quite strong reductions for outcomes. If you take here heart failure hospitalization and CV death, the hazard ratio is 0.72, a 28% reduction for this combined endpoint. And why don't you just keep that in mind? Data predicts data. And of course, you know already the key outcomes. You will already recognize that this is a number very similar to what we know. If you look here at heart failure hospitalization, 25% reduction in EMPA-REG outcome. There's also, and this is unfortunately, as you already know to some degree, not quite as predictive, also a strong reduction in cardiovascular death, but you also see here the confidence interval. So maybe this is a lesson to learn that data predicts data with a spectrum of variability, of course. Now, a heart failure development program was developed after the successful studies in diabetes. There was also a development program in kidney disease, and there's even now one with ongoing studies in myocardial infarct. But coming to the heart failure program specifically, you know that the DAPA-HF and the EMPEROR reduced trials were positive, reported 1 and 2 years ago, respectively. And if you look at the meta-analysis of these two trials, you can see here for cardiovascular death, a 14% reduction. And you can see for the combined endpoint of heart failure hospitalization and CV death, a 26% reduction. So very much a beneficial result and very much a homogeneous result for these two tested Sglt2 inhibitors in heart failure with a reduced ejection fraction. This was true for patients with and without diabetes, very similar results. And this was true basically regardless of where you're coming from, and concerning you coming from India, Asian data looks very good and homogeneous, more than 35% reduction in heart failure with reduced ejection fraction in Indian patients alone. So this tells us that Sglt2 inhibitors should be used in patients with reduced ejection fraction heart failure. And in addition, the soloist trial suggests that maybe we can move the use of these medicines even closer to the hospitalization, because soloist was started at the end of the hospitalization and within 3 days of the hospitalization having ended. So this basically suggests Sglt2 inhibitors are useful, and also in recently discharged patients can be used. Whether you can use them for full-blown acute heart failure is actually still an open issue. Now, with this data that we know about heart failure with a reduced ejection fraction, the new guideline came up with the 4 pillars of heart failure with reduced ejection fraction therapy: RASI therapy or NANI, beta blockers, MRAs, Sglt2 inhibitors, with very strong class 1 recommendations, and loop diuretics for symptom management. Now, specifically, you can see here the recommendation as published yesterday in the European Heart Journal. And I sent a link about this publication in the PDF file to colleagues from Lupin and to Vijay Chopra. And so this should be available now for everybody who wants it. There is no problem in distributing this. So ACE inhibitors, beta blockers, MRAs, are recommended class 1A. Please consider that dapagliflozin and empagliflozin, they are recommended for patients with HFrEF to reduce the risk of heart failure, hospitalization, and death. And sacubitril valsartan is also recommended. Unfortunately, in my opinion, only with a class 1B. It should have been class 1A, I believe. Very large data set supporting this, but technically, of course, only one trial. But we can argue about this. So dapagliflozin and empagliflozin have a class 1A recommendation, which is new. So how does this fit in the overall management recommendation of the guidelines? And here you see the treatment algorithm for heart failure patients with a reduced ejection fraction. In green, the treatments recommended with a class 1, and you can see here some notes related to this. And if patients then have low ejection fraction with a very narrow QRS versus basically having sinus rhythm and then low ejection fraction and a wide QRS, you distinguish between these patients and give either CRT-DNP or an ICD possibly when they are at risk. And of course, you can give additional therapies, and there is a patient profiling approach now where, depending really on the patients, whether they have atrial fibrillation, iron deficiency, or just basically ischemia, whether they basically have valvular disease, you do additional things and use therapies to manage patients individually according to their patient profile. Now, all of this is done for heart failure patients with reduced ejection fraction, but these are only 1/2 of the heart failure population overall. There is also the patient with a mildly reduced ejection fraction or those with a preserved ejection fraction. There is a lot of debate where the cut point starts for a normal ejection fraction. 50 to 55% is in most textbooks. Some would argue 60%. In any case, with a preserved ejection fraction means patients without a clearly reduced ejection fraction. And so we have these three groups. And you basically, in this diagnostic algorithm, you suspect heart failure, look for risk factors and symptoms. Maybe natriuretic peptides can guide you. But if they are very normal, it's like an exclusion criteria, then heart failure becomes very unlikely. If heart failure is not excluded as a possibility in patients with shortness of breath and other signs like edema, then echocardiography is warranted. And if you have abnormal findings, heart failure is confirmed depending on the ejection fraction. And then you have these three classifications. When you look more specifically for the heart failure patient with a preserved ejection fraction, you can see here that you should aim for documentation of objective evidence for structural abnormalities, for instance, E over E prime being abnormal, or for instance, that the left atrium is enlarged, or that, for instance, filling pressures are raised, or even natriuretic peptide levels are raised. So there's a variety of ways to confirm this diagnosis. And this is important because we have specific trials for these patients. And the Emperor Preserved trial is the first of the heart failure with preserved ejection fraction trials to report. As I said, there will be other trials reporting in the near future about myocardial infarct or even about kidney disease like Emperor Kidney. So we started this trial program about 5 years ago with quite a degree of optimism. I showed you already the heart failure subgroup results in EMPA-REG. And we wondered ourselves what these patients with heart failure in EMPA-REG were like. Were they more like HFrEF patients or more like HFpEF patients? Now, we didn't have natriuretic peptides levels, New York heart class, or ejection fraction. We only had event rates. And basically, we looked at the event rates for these patients and saw that the, here in this case, hospitalization rates per 1,000 patient years of follow-up in that subgroup matched the rates seen in other HFpEF trials. If you look for mortality, the same picture. The mortality in that subgroup was very similar and lower than is known to happen in HFrEF trials. So personally speaking, looking at that data, it was for me rather likely that this subgroup was HFpEF patients, and therefore past data predicts future data. I was optimistic about the outcomes of the trial that we then designed. And this was the Emperor Preserved study, where we aimed to evaluate the efficacy and safety of empagliflozin versus placebo in patients with preserved ejection fraction heart failure. In other words, with ejection fraction above 40%. And as is still demanded today by the guidelines, they had to have structural heart disease or heart failure hospitalization in the last 12 months. 10 milligram once daily, EMPA versus placebo, 26 months follow-up, so a little over 2 years. and primary endpoint, time to first event for cardiovascular death or heart failure hospitalization. Key secondary endpoints, the first and recurrent heart failure hospitalization, and the slope of change in GFR. So very similar to what you've seen before in reduced ejection fraction heart failure, now done here. Executive committee, I had the chance to be the PI of the Emperor Preserved study. The overall committee is chaired by Milton for the reduced and preserved together. The trial also, of course, is only possible when we do this in many countries in the world. 23, you see here the national coordinators from India, Vijay Chopra, adjudication committee, data monitoring committee, and here you can see the countries of the world where this is done, and more specifically, India had participated also, like a number of other countries, to recruit patients. And this is very important. We're very thankful for that. 11,500 patients were screened, almost 6,000 were randomized, 2,997 EMPA, 2,991 placebo. We basically had vital status on these patients except for 36, so 99.4% complete. This is very good in terms of the survival status. For the primary endpoint that also included heart failure hospitalization, we had 97% completeness of the follow-up. Now, here is the key characteristics for how the patients look like in terms of age, 72 years, 45% women and 49% diabetes, so half-half diabetes, no diabetes. Ischemic etiology, 1/3 of the patients, 80% in New York Heart Class 2. So the mean ejection fraction was 54%. I come back to this in a more detailed. NT-BNP 950 to 60 on average. Can you imagine half of these patients at baseline had atrial fibrillation? So really a big issue for HFpEF patients. GFR was highly variable, 50% below 60, and the average was exactly 61. But look at the baseline therapy. That is essentially already a HFrEF therapy. And despite only 1/3 officially with an ischemic etiology, you can see 70% had statins, 86% beta blocker, 37% an MRA, 80% had already an ACE inhibitor and ARNI on board. So this is already good therapy from a heart failure and comorbidity perspective. 90% of the patients had hypertension. So this is the primary outcome slide. Placebo, 511 patients had an event, and this gave a rate of 8.7 per 100 patient years. So this is the EMPA group. You've seen this, of course, before. If you watched yesterday and you hear it, we have almost 100 less primary events. And when you do the comparison, it's a 21% reduction with a p-value of 0.0003. And this equates to a 21% reduction with the number needed to treat for this 26-month period of 31. The interesting additional point, this Kaplan-Meier curve was different already from day 18. So this is very early separating curves that then remain significant throughout the trial. Always of interest, the components of the primary endpoint. Here they are. And if you now remember what I showed you about the subgroup of heart failure patients in EMPA, first heart failure hospitalization, 29% reduction, cardiovascular mortality, and 9% reduction. So basically, we are not seeing a benefit for cardiovascular mortality that reaches significance in its own right, but it goes definitely in the right direction. But where the success of the primary endpoint is carried is with heart failure hospitalizations. So here are the subgroups. We had in total 13 subgroups pre-specified. And amongst them, you can see age and sex and race and BMI, GFR, and also diabetes. Diabetes, no difference. I'm just highlighting a few p-values for interaction. None of these 13 p-values is anywhere near significance. So here you can see diabetic and non-diabetic patients actually significant within the subgroups. So a very good and reliable result. And you remember the issue about ARNIs and the sex interaction, and you can see both for men and for women in this trial, significant in its own right. So this therapy is beneficial both for men and women. Here's the second set of subgroups that was pre-specified by etiology, by prior hospitalization, by ejection fraction, anti-BNP, and other therapies given. You can see here that on top of an MRA or not, it basically works. There is no significant interaction. Also, when you have the ACE inhibitor ARBs on board. There is only 2% of patients with an ARNI in this trial. So doing a specific analysis for ARNI patients is not possible. But RASI therapy, yes, no, you can see here also significant in its own right for both subgroups. But of course, many people are interested in the ejection fraction subgroup. So this is highlighting that result. And when you look at this you can see that there is no significant interaction for the primary endpoint for this study. Now, the hazard ratio goes, of course, slightly up, but it remains below 0.9 for all these groups. When you look into the secondary endpoints, here for the first one, which is the first and recurrent heart failure hospitalization. Again, remember the subgroup of EMPA-REG, 27% reduction. Very significant result as well, and a very meaningful result. And you get this already in the first 3 months. You can save hospitalizations, but you save them throughout. And this is the Gfr change slope. And you see there is a significant result. And this is a quite interesting point here on the right side. When you look into the off-treatment GFR, where basically at the end of the study, 30 days later, you reassess the GFR and compare it to the absolute baseline. And don't forget, there is a dip initially. And here is a minus 3.3 30 days after the trial. So essentially, you have a dip, but then the GFR stays the same all throughout. And the value of 1 month after the end of the study for the placebo group is minus 5.7. So it's about here. For both, basically these treatments, you can say that there is a decline in kidney function over time, but this is slowed with empagliflozin. So as a summary for these results, a highly significant result for the key outcomes of this study, a full success also in HFpEF for the primary endpoint, cardiovascular mortality and heart failure hospitalizations, but also for the 2 first secondary endpoints. There's other secondary endpoints, and they include, for instance, a measure of quality of life with the clinical summary score for KCCQ. And you can see here a significant result also for this. We have very few comparisons because we simply don't have successful other therapies in HFpEF, but there is no drug that has a bigger effect than this. This is a good effect for HFpEF patients. We shall look into this further, how we can basically make an objective assessment, how much of a quality of life improvement we want and is meaningful for the patients. Symptoms also improved. More patients on EMPA got into a better New York Heart class. but also less patients got into a worse New York Heart class. So it works in both directions. A benefit seen that prevents deterioration and supports also improvement, very useful for the patients as well. Now, here you can start to discuss mechanisms. So what is this therapy really doing from a biological standpoint? Glycated hemoglobin, a small change. Don't forget, half the patients were non-diabetic. And we know that the impact on hemoglobin A1C with empagliflozin and other Sglt2 inhibitors is limited. A rather strong increase in hematocrit, 2.4% increase, but accompanied by only a little change in NT-BNP. Where this is a diuretic, you would expect a much bigger reduction in NT-BNP combined with the hematocrit increase. So maybe this is more a metabolic and erythropoietin-mediated change in red cell production. I think it is, if there is a component of a diuretic in empagliflozin, first of all, it's a good diuretic, not causing neurohormonal activation, but also it's a successful one reducing events. Body weight, 1.3 kilogram down. In HFrEF, it was only 0.7 kilogram. So that's a quite surprising result, and we will look more into this. The systolic blood pressure going down 1 millimeter mercury. So all-cause mortality, we need to look further into this, why we couldn't achieve anything there. All-cause mortality is, of course, not something that we are striving to improve with the cardiovascular drug. And total death numbers were basically equally high for cardiovascular and non-cardiovascular death. But this is something we need to explore further. Safety issues. Look at particularly ketoacidosis, bone fracture, lower limb amputations, nothing. Also nothing for hypoglycemia, no problem at all. There's 2 points that you need to be aware of. One is symptomatic hypotension, 1.5%, and genital infections, mostly mycotic in nature, 1.5% increase compared to placebo. They are manageable, they are mild, they are not a big safety issue, but you need to be aware of it. So when you compare now the ultimate results of Emperor Preserve with the previous trials, you can see a range of 5 to 14% primary endpoint reduction with other drugs before, with p-values that were non-significant. And regardless of what you think, certainly this was not an overwhelming success for any of these medicines, whereas with Emperor Preserve, we have a clinically meaningful and important difference that we can document for patients. We can basically say that Emperor Preserve is the first trial to show unequivocal clinical benefits with a drug in patients with heart failure and a preserved ejection fraction. The effect is clinically meaningful and sizable and highly statistically significant, and it is present independent of subgroup characteristics of patients. Now, they include ejection fraction, sex, and diabetes, and so we can basically think that this is wildly useful, and we published this yesterday in the New England Journal, and VJ is amongst the co-authors and many others. So this was a big success. But there was a second study that we reported yesterday. And so allow me a few extra minutes on Emperor pooled, which is basically 9,718 patients together. This is a prospectively designed and powered analysis of taking the patients together from Emperor reduced and Emperor preserved and look at major renal outcomes as the primary endpoint, and then other important cardiovascular outcomes. So let's first of all compare the two trials for their overall effect on the key endpoints: cardiovascular death and heart failure hospitalization. You can see here very similar hazard ratios, big number of events, significant results, heart failure hospitalization, cardiovascular death, again, very similar results. Within 1 or 2 percentage points, similar results. And also for total first and recurrent hospitalization with heart failure, you have a 30% and a 27% benefit for empagliflozin versus placebo in heart failure patients. Now, because of the success of both these trials, this major renal outcomes analysis was possible. And I would like to highlight the fact that we used, and now in hindsight, we might say, unfortunately, a renal events definition that was using eGFR change of 40% and higher as one component and did not include renal death. Now, these are the results. On the left is emperor reduced. On the right is emperor preserved. And what is important here is this significant interaction that the results are different between the two studies. Because they are different and are heterogeneous, you are not allowed to pool them. So here we have a very unusual situation that we prospectively plan such a study to be pooled, and we have an equally unusual situation that we are then not allowed to do that pooling for this statistical reason, that there is simply a difference in the outcomes. So when you look into emperor preserved, on the left, you have the GFR change, significant. On the right, the major renal outcomes, no difference, 5% reduction only for the endpoint chosen. Of course, this can mean that maybe the two things are not related, but I don't think that's an issue. GFR change is something that is important to prevent, and so this is still good news that we achieved this. Second conclusion, maybe this is far too short a follow-up for HFpEF patients to show renal benefits. We can't say this yet. This may be true. Let's see whether the DELIVER trial shows different results on this. We will learn this. But there is another possibility that really the definition we used was suboptimal. So here, first of all, you see by ejection fraction the results in the two trials. There is no relationship of ejection fraction to these outcomes, but the major outcome being related to the 40% GFR change for the patients. So you can see here below 30 and above equal, this is similar results for the reduced. And here in the preserved, you can also see very similar results. It didn't work is the baseline, but the typical definition actually used, and for instance, the DAPA-HF trial used it also, is to use a 50% cut point and to include renal death in the endpoint. And this was actually also what we used in the meta-analysis with the Lancet. So here is what you see when you do that. And you basically can see here that the overall reduction from 5% becomes a 22% reduction. Still underpowered, but looking much better, a 22% reduction in events. And here, sorry, it's a bit skewed, the presentation. You can see that the ejection fraction has no relation for the 40% and above, as told you before, but maybe then for the patients, when looking at the 50% definition, you suddenly see something where the results, particularly in the lower range of ejection fraction, do resemble what we have seen in emperor reduced. So from these two studies, we have this weekend 5 publications. 2 came out yesterday and 3 will come out tomorrow. However, 2 of them are commentaries and 1 is a full paper in circulation. But the commentaries each contain original data. That's why they are mentioned here. So let me summarize overall. We have basically in emperor preserved a success that is highly significant for the 3 key endpoints that are important for these patients: the composite of cardiovascular death and heart failure hospitalization, first and recurrent heart failure hospitalization, and the slope of decline in GFR. We now can say that the heart failure program with SGLT2 inhibitors has an additional successful trial under its belt. The SGLT2 inhibition story in heart failure is a full success so far, and still there is more to come in patients with heart failure, DELIVER, but also MPULSE, acute heart failure, and also post-MI with a lot of heart failure we will study as well. What remains to be said is that the use of these medicines is important. We're all doing not good enough a job. Many patients don't receive the heart failure therapies they should, despite having indications, despite not having contraindications. And so we need to, these blue boxes that are in part very big, we need to make sure that patients get the therapy. SGLT2 inhibitors have no electrolyte imbalances like quite a number of other therapies for heart failure have. So there is no reason from this aspect not to give it. SGLT2 inhibitors, basically, they have a once daily dosing. They have only this one dose anyway, no titration issues at all. So it couldn't be more simple to use this medication. Let's do it. And basically do it in heart failure patients with a reduced ejection fraction as one of the pillars of the 4 pillars of therapy there, where we have clear indication from the current guidelines. And maybe also let's do it for HFpEF patients already, or let's do it very soon when the next guidelines, I'm sure, will recognize these results. So I think you've seen that our HFpEF patients already were to quite a large degree treated with these kind of medicines. And now let's add SGLT2 inhibitor as a new standard for HFpEF patients. Empagliflozin is the only SGLT2 inhibitor where you have a proven efficacy across the full spectrum of heart failure. It shall be interesting to see how now we can change reality for our patients implementing this. Thank you so much for your attention.
Thank you, Stefan. That was a wonderful presentation, and congratulations on bringing this therapy for several of our patients who had nothing, for whom we could offer nothing. Let me start with this last comment first. We have wonderful therapies, but what's the use of those therapies if we don't apply them? So the therapies are still grossly underutilized. Even when they are given, they are not given in appropriate doses. So I think it becomes very important for all of us to impress upon our colleagues that not only therapies need to be used because in proven doses, but all of them need to be used and as quickly as possible. The other thing which has been brought out is that all these 4 therapies should be on board as early as possible, because delaying them or reaching one ideal dose of one particular drug and starting the other one later on doesn't work. It's too long. The maximum mortality is within the first a month or something. So earlier we get all these drugs on board, the better it is. So with that, let me open the discussion. Dr. Mulasari, your initial comments, please.
Yeah, I agree with you, Vijay. I think this is the start for heart failure with preserved ejection fraction management in a very, strong, organized way. I think that these drugs, along with maybe the beta blockers, aldactone antagonists, and ARNIs, may be the right approach to patients with heart failure with preserved ejection fraction. I was also quite happy to see that it helped in most of the subsets, only think 60 to 65%. I saw Dr. Packer, Milton Packer, also saying this, that we need to have some more information in that area. Up to 60 seems to be okay. This drug seems to work pretty well. Also, the renal disconnect is quite interesting, and I agree with Stefan that disconnect seems to be a disconnect of time, and I think maybe with time it will show renal endpoints getting better.
Dr. Kahali, your comments?
Yeah, thank you. First of all, Dr. Stefan, for your excellent lecture. It's a superb lecture, and I was also a participant like Dr. Chopra in this study. And we have been using even before the publication in such patients with proper indication, of course, and the results are very good. The reduction of primary mortality, primary endpoint, the mortality and the first heart failure hospitalization by 21%, and the hazard ratio being so low is really fascinating, because till now we haven't got any drug to treat heart failure with preserved ejection fraction. The TopCat trial came, and Dr. Mayers from Boston told that it's very effective, but subsequently it is disputed. Beta blockers also unequivocally once it was used, but now it is told it's of not of much use, much benefit. So really we have certain drugs for heart failure with reduced ejection fraction, but heart failure with preserved ejection fraction being a difficult entity, and we haven't got, of course, we use the drugs we use in the HEP-REF patients, but we haven't got any definite indication. But now we have got a drug which is effective and which has been proved in a randomized trial. Just I have got one question, that you have mentioned that the drug discontinuation rate was as high as 23%. And there was 12,000 patient random screen and 6,000 odd patients randomized. So why the randomization and screening was so different? Almost 50% patient missed the trial for randomization, and why 23% of the patients had to discontinue the drugs? As clinicians, these are really important to us.
Well, first of all, thank you so much for these two questions. The discontinuation is, of course, a combination of many things. Some people simply don't like to take medicines anymore. Some patients, the physicians are concerned that after a first or second hospitalization, they want to stop giving these medications. Some people simply don't want to go anymore to the visits of the study, or simply some people see the data coming out from other trials while this trial is going on, have an ejection fraction of 45% maybe initially. In the meantime, the ejection fraction is below 40%, and maybe some physicians decided to stop the trial for this patient, or the patient decided to stop the trial and just get the medicine open label. This is something we have described in the supplement of the New England paper. There is not a single reason that stands out as being the key reason there is no significant difference between the group for these reasons. So in that sense, this does not tell any story about possible problems. They are very equally distributed. Now, in terms of the screening failure rate of 50%, let me just say that I consider this, first of all, a normal screening failure rate. And because we see that essentially in all trials, if anything, we see very often also worse ratios. And this is mainly due, and this is like 80 or 90% of the cases that failed screening, failed them because of the natric peptide levels. That was the major reason for failing randomization. Sometimes it was other things like the GFR being below 20 or whatever else, ongoing infections, etc. But 80–90% it was natric peptide levels being too low.
Stefan, I think since there was an equal discontinuation rate in both the arms, we must remember that this was in COVID times, and a lot of people probably just didn't want to come anymore. Sometimes people have to travel long distances. Didn't we see a drop in people coming to the OPDs so significantly?
Yeah.
Even when people were very sick, they didn't want to come to the hospital.
Yeah.
So I think that was also one of the very, very major reasons. Dr. Srikanth, your comment? Yeah, sorry.
That is very true. There will be future publications on this issue specifically, but I can tell you that quite a lot of follow-up visits, 20–30% during COVID times, were actually done remotely.
Yeah.
Even end of study visits were done remotely. And so that is indeed also the case, that some patients, because of COVID, just didn't want to come to the visits anymore.
Dr. Srikanth, your initial comments, please.
Yes, sir. A couple of interesting thing was there was no change in the NT-proBNP. That's what I noticed. And were diuretics used in the trial? Any information regarding that?
Diuretics were used in the trial, and there will be a specialist kind of publication on the use of diuretics in preserved. I don't have all the data at this moment yet for this available, but it might be a good reason to have another webinar towards the end of the year.
Stephen, these results are fairly reminiscent of what we saw in Paragon, that people, when their ejection fractions were closer to the reduced ejection fraction, they seem to derive benefit. Of course, the magnitude of benefit was much, much more in this trial than it was in Paragon.
Yeah.
So do you think in the sub-analysis, I'm sure you'll do a sub-analysis in which there'll be people who were both on ARNI and on empagliflozin. Might it be that they would derive greater benefit?
I would find it very unlikely that there is a meaningful analysis of this, Vijay, because as I said, only like 2% of patients had such. So with 2%, you have that's basically 120 patients out of 6,000. You can't do this analysis. That is unfortunately not possible.
Any thoughts on why people over the age of 60, elderly people didn't get enough benefit?
I'm very happy to look at with you.
I think they were more benefited, sir.
Well, it was basically by age of 70 we divided.
70, yeah.
1 second. Shall I share briefly the data? So I think that's always best done with data such. So look here at the age below and above. He's below 70. They have.
I think I got that wrong.
The interaction between these two is 0.25 or something like this.
And ejection fraction over the age of ejection fraction over 60 or 65. Any thoughts on that? Any preliminary thoughts?
This is yes. Let me clarify something. There is how shall I say it best? The trial had pre-specified subgroups, which was 40 to below 50, so 41 to 49, 50 to 59, 60 and above. And it had a primary endpoint, and there was no interaction for the primary endpoint looking at this data. The primary endpoint is 1/3 cardiovascular death and 2/3 heart failure hospitalizations. Now, there is additional cardiovascular death happening after a first heart failure hospitalization, going then, of course, into the cardiovascular mortality endpoint. There is additional information from heart failure hospitalizations that are second and third, etc., hospitalizations going into the recurrent events endpoint. Now, when you saw Milton Packer present on ejection fraction data using fiver cut-ons, so basically 25, 35, 45, 55, 65. Let me very clearly say this is a post hoc analysis, not on the primary endpoint, but on a secondary endpoint, which is heart failure hospitalization. So these analyses were definitely not pre-specified. They are post hoc ideas that are interesting, can raise discussions, can generate hypotheses, but from a scientific standpoint, they're not even at the level of the subgroup analysis by, let's say, sex for the primary endpoint. They're really non-pre-specified, not on the primary endpoint. That's I would like to make this statement first of all. The results that you saw with 65% and above, where there is basically an attenuation of the effect on heart failure hospitalization, That is true. But actually, the number of patients and the number of hospitalization in those subgroups becomes minute. We are talking about 30, 40, 50 or so such events. I don't know what it means. It may actually mean that above 65% you have no heart failure at all, or you have a different kind of disease, or simply it means chance. I don't know.
Was there a difference in diuretic dose use in EMPA and placebo arm? Have you analyzed that? Not yet.
I can't, I may have seen a limited number of data. I don't want to say this way or that way because at the moment I don't have it at my fingertips. I'm very happy to figure it out in the next days and say something about it. But it's also not really published yet. So it will be a bit difficult if it is unpublished information. So I don't know.
Stefan,
My technical answer will be in the next 3 months we will publish on this.
3 people have asked a question that using a dose of empagliflozin of 25 milligrams, would it have given greater benefit?
Well, first of all, in such a big trial, we will never know. That's my first comment. My second comment, I'm doubtful. There is, for good reasons, is there a rule in medicine that when you have 2 doses available, use the lower one if it gives you the same effect? And in EMPA-REC, both doses gave the same effect. Now, in a very big patient, you know, when you have diabetes, severe obesity, and you want to use this drug to protect the kidney, protect cardiovascular outcome, but also to reduce hemoglobin A1C, in addition to other medicines you're using, then maybe you can actually increase to 25 milligram for the diabetes therapy. For the heart failure therapy, let me say it this way. I know that there is an abstract late breaking submitted to American Heart about using the higher dose in a setting of acute heart failure, really decompensated heart failure. I see a possible future in that range, where then basically for short periods of time, you may manage patients with higher doses of empagliflozin, but not chronically outpatient approach. This was a study in patients with a real acute decompensation.
Any questions from our panelists? Yes.
Is there any data, Stefan, in obstructive sleep apnea patients?
No, not at all. Very good point. Many of them, you could even ask, is there any data whether in our patients sleep apnea kind of improved? Unfortunately, I don't have any suggestion that this could be the case, but I will take this point and ask whether sleep problems were recorded in the adverse event profile, and maybe we have by chance something that could be kind of taken from this. But this will be something that needs special studies, sleep studies in heart failure using Sglt2 inhibitors could be an interesting thing to do.
Why that particular question? Do you have any information on that?
I find that a very difficult group of patients to treat, Vijay. And just like preserved ejection fraction was difficult for us to treat. I think amongst the preserved, I think 2 groups, the OSA and the atrial fibrillation group of patients, were the hardest to treat for heart failure with reasonable ejection fraction in my practice. That's why the question.
Yeah, I agree with Dr. Ajit. Like patients with preserved ejection fraction, they are the ones which trouble you to manage, whether it's because of lack of choices. But in the trial, they did pretty well compared to the ones with compared to reduced ejection fraction. The event rates were slightly lesser. But clinically, these patients give you bigger challenges. Now we have Sglt2. We should see how how it will make a difference to our practice.
Yes, the event rates, for instance, of mortality were half in emperor preserved compared to emperor reduced. That's true.
I didn't see a subset analysis for atrial fibrillation, though there was a history of atrial fibrillation in the clinical data. Yeah.
I'm sure you will appreciate this to be a very exciting and interesting topic, and you shall look forward to a paper in one of the big cardiovascular journals again in the next 3 months, 4 months about this. It's in the first wave of additional publication. This is part of it. This is an important issue. This was not a pre-specified subgroup, and this is why we didn't report on it. But it is a very interesting group to consider indeed.
Again, because I'm just saying, because drugs like the finestron for the aldectron antagonist, they seem to be creating some lack of fibrosis in the atrium and less AF. Do you think something like this would happen with SGLT2 or no?
Well, this is that's speculative, but because now we no longer talk about a subgroup of AF, but maybe new AF development. This is the main reason why AF was not pre-specified as a subgroup, because we consider, generally speaking, the tick box diagnosis of AF from a patient recruited into the trial as rather unreliable. So what exactly does that then mean? But if you take AF from the baseline ECG, that is more reliable, and this will be available for us to look at. I haven't seen that data, but it will be published very soon.
With these results coming in, Stefan, are there any new thoughts about the mechanism of action? Does it change your perceptions, or you think?
Well, tell me, Vijay, do they tell you anything about mechanism very much?
I don't know. You are the wise guy.
Well, but then if you remember, I'm the wise guy who says actually that he doesn't care much about mechanism of action. I care about successful drugs. So mechanism of action discussions are for upper management to feel happy approving $100 million to be spent. Mechanism action discussion are really speculative. You cannot possibly prove and positively prove a mechanism of action. It's not possible. You can only exclude why something doesn't work. That's called falsification. That's the way we do our science. We, of course, you can come very close to the truth in many cases, but it must be obvious to everybody that Sglt2 inhibitors are amongst the drugs where coming to the truth very quickly is not possible. You know, there's two things that stand out with this drug from a biomarker profile in emperor preserved. One, and you have seen the data, is the change in hematocrit. And you might say the second thing that stands out in this context is the rather small change in NT-BNP. Don't forget, it's significant, but significant with a 5% difference. Okay, so it's maybe you could also argue, maybe that's the way we should analyze the data. Every fourth patient has a 20% reduction, but everybody else has nothing. And so, okay, but there is a second thing that stands out that where you haven't seen the data from this trial, but I'm happy to tell you that uric acid is also strongly reduced. So to me, that points in the direction of being an insulin sensitizing drug. So it reduces insulin resistance. It also promotes excretion of uric acid. It's to some degree also a uricosuric drug. So these effects are very interesting. But how does a uric acid reduction then help a heart failure patient? At least when we try to do this with xanthine oxidase inhibitors, we didn't get much of a benefit. So maybe there is a difference for uric acid per se. Now, I don't know how much everybody of you is into immunology. Around about 15 years ago, there was a Nature paper about uric acid and as a death signal. Why is it a death signal? Well, uric acid really only comes into the circulation either because xanthine oxidase is activated or because you have release of purine bodies with cell death. When cells die, they release the cell core, and the cell core has purines. They are degraded and become uric acid. So in that sense, uric acid signals dying cells. Now, what does that do? Uric acid interacts with the CD14 receptor on cell surfaces and makes it hypersensitive to endotoxin. So dying cells stimulate a hyperreaction to any kind of immune stimulus, and a reduction in uric acid basically has a chronic anti-inflammatory effect, particularly not a chronic anti-inflammatory effect every day, but during times of immune stress, infection, etc. And such infection, as you remember, comes, for instance, during edema phases. I don't know whether you remember our very initial Lancet papers. We're talking 1999, 2000, about endotoxin as a trigger for immune activation in heart failure. And so when you have edema in the legs, you have edema in the gut, you may have bacterial translocation during decompensation phases. So and a uric acid reduction will lead to less inflammatory damage at a time of decompensation. It's speculation, but if you wanted to hear a cool little mechanism, that is what I'm interested in.
I didn't see any inflammatory markers at all being talked about, HSCRP or something like that.
Not done yet. There is a 1,200 patient sub-study planned with biomarker samples. 1,200 patients emperor reduced, 1,200 patients emperor preserved. And there will be a wide panel of things, 30, 40 things will be measured. And this will, I think, let's call that the next 12 months, a big project. Fayez and others.
Stefan, in your personal practice, we can't tell anything from this particular trial, I admit. Have you found any difference between dapagliflozin and empagliflozin so far as heart failure with reduced and preserved ejection fraction is concerned? Because you have a huge experience on this field.
Yeah, but I have a huge experience with empagliflozin, not with dapagliflozin.
Okay.
Now, for better or worse, this basically, let's take a very simplistic approach here. I'm practicing what I'm doing research with, and it's so much. I mean, but look, 10 milligram once daily. It's the one drug. It's the other drug. The data is very similar. So when there is no practical difference, and you are in the habit for the one drug, why bother? Now, of course, in HFpEF, there's only one drug with the evidence.
Yeah.
The other drug, probably will be at the American College next year or so. So we need to wait a little. But no, I don't think there is much of a difference, but I do not have a big experience with dapagliflozin personally.
Thank you.
Okay.
So what next, Stefan? We've now reached Sglt2 and we've, sort of got a dose at it, and we know now.
It's a very fair question. I mean, I'm involved in the EMPACT-MI study, so empagliflozin for post-MI patients. I have put in for, again, I should say, I've put in again for a COVID/influenza empagliflozin study, because I personally think that as much as you have long COVID, you also have long influenza. and at least when it comes to the more severe forms of an influenza, and we would only include patients that have raised natriuretic peptides or troponin values during an viral infection phase, and then would treat not like DARE19 would not only treat 1 month, but 6 months at least, and would hope that we can prevent cardiorenal deterioration or long-term damage, including, for instance, what was mentioned already, fibrosis development, post-COVID, post-influenza. So trying to prevent long-term damage of such short-term infections by using empagliflozin. Can't tell you whether this will be approved for support, but it would be nice. Otherwise, and now we are talking beyond empagliflozin, you know that we are running our morbidity mortality trial with ferricarboxymaltose. I'm doing one with mitraclip in mild to moderately severe functional MR. So these trials are ongoing. And next year, we will report on the potassium binder results in the Diamond trial. So from a heart failure perspective, many things ongoing. But then also, of course, we have cardio-oncology, and you may know that I do lots of cachexia stuff. So that's a reason. I'm reasonably busy.
What about NASH, non-alcoholic?
Well, interesting. I do not know whether there is NASH plans for Sglt2 inhibitors, but yes, NASH is coming to the forefront of attention with cardiovascular outcome trials also planned. We are just starting one trial, and you're talking there about 7-year follow-up periods and stuff. So these are long-term projects. NASH is a little bit tricky in that regard.
I was also quite amused by the fall in blood pressure. Why not as an antihypertensive, this drug?
Well, 1 millimeter, I mean, I don't know. Maybe the fall is bigger with a 25 milligram dose. I have no idea, precisely speaking. Maybe the fall is bigger when you have a bigger starting blood pressure. Let me say it this way. In diabetics with hypertension, you can already claim it's indicated, I would say, because of diabetes, and certainly would be a useful thing to do for long-term prevention of cardiorenal problems. In terms of short-term, I don't know. This is not so evidence-based.
This is one of the advantages that we claim for Sglt2 inhibitors, that they don't cause a huge drop in blood pressure, isn't it? So,
yeah.
Okay, any other comments? Stefan, you are going to be back at ESC in the next 5 minutes.
Actually, I'm in 15 minutes, we'll do another webinar.
Okay.
So in that sense,
so any concluding remarks from you, Stefan?
Stay busy, I guess, and that's good.
Any concluding remarks from you, Stefan?
I think we're all doing a fantastic job in doing good research. Now we need to do a fantastic job in implement these medicines. We have good medicines available. Let's use them.
Thank you, Stefan, and thanks, Ajit, Dhiman, and Srikanth.
Thank you very much.
Wonderful discussion. Dr. Stephen Anker, as usual, that's his whole style of presentation.
Fantastic.
It's mesmerizing most of the times. Thank you, Stephen, and we look forward to meeting you again very shortly.
Yeah.
Over to you, Rohit.
On behalf of Lupin, I sincerely thank Dr. Stephen for sharing Emperor Preserved trial findings in detail. It was a great presentation, sir. And it was a qualitative discussion on findings by Dr. Chopra, Dr. Ajit, Dr. Dhiman, and Dr. Shrikant. Thanks a lot, sir, for sharing Indian perspective and implications of Emperor Preserved trials. I also want to thank all the doctors who have joined virtually and attended this session. So thank you very much to all the doctors, and have a great weekend. Thank you all from Lupin.
Bye-bye.
Bye. Thanks.
Thank you. Thank you.